Thank you very much, everybody, for coming back. I hope you had a good rest, short rest, had your sustenance and medication for all the patients. And thank you for bearing with us that we ran the last session slightly over 15 minutes or so. But as my friends tell me, it's AMT. There is GMT, and then is Africa Mean Time. We do have some problems sometimes, but we have on average managed the time. The next session I think is very important for us for two reasons. One is a very personal, but one is very scientific and of importance from a public health policy point of view. Throughout, since yesterday, we have been going on and on and on and on that we need to go and reach this universal health coverage 2030. We are on target, we are off target. And we saw innovation, we had this, we had copious amount of patient co-generated information. There's industry partners who are bringing in innovation. There's a whole host of other players bringing in innovation. And the question that finally remains is, how do we make this choice? How do we invest in this innovation? What innovation over what other? What are the criteria? We know Africa, having grown up with the Ministry of Health, and we heard of huge waste of schemes, wasteful schemes, building fisheries in places which have lakes that dried up, building mega dams which didn't even produce a kilowatt of energy, agriculture project trying to grow rice in the desert, all these things we have been grown up as little children heard this. And we said, there is waste. How is this decision being made? So today, I think for this wrap-up session, I've got two excellent speakers, and both of them have really influenced the world over, I think I would say, this decision-making, how to do. My first speaker will be Dr. Dalia Dawoud, who is a scientific advisor at the National Institute for Health and Care Excellence in UK. The NICE is the oldest body that was created to shadow our universal health coverage here in the UK, the NHS. Dr. Dalia has also taken a lot of issues and has been well published. I would actually ask everybody who's joined us, please do search on Google Scholar, and you'll find the amount of work she's produced is amazing, and it is work that is all applicable, and it all is waiting for us to implement in Africa. This is something she's written from deep down in her heart. I also liked her approach when she joined up with the HTX. This is the next generation of health technology assessment. And she's like building this up into a huge affair. It's what I call the patient-centric approach to many things. And to crown her glory, she's also got, as an associate detail of ISPO, the General Value, and has written extensively on this and has brought in great scientific thought and rigor into this. Her word is trusted by our top ministers right down to the civil servants, and we really respect her approach. My next speaker is Dr. Mohamed Gad. He's a health economist at the Department of Global Health and Development, Faculty for Public Health and Policy at London School of Hygiene and Tropical Medicine, my alma mater. And I think they have, Dr. Gad has really put across the importance of decision-making in Africa. He has really been on the forefront of trying to look at how decisions are made. And his involvement in the International Decision Support Initiative in Africa has been very good, because Dr. Gad has really pushed forward HTA, knowledge, skills transferring, and capacity building in both these environments, and has brought this great initiative together. And he will share up on the last part of it. How are things rolling practically? What are the pushbacks and what are the early takers? And as I said, the next move is going to be whole of society working with whole of government, whole of provider And these are societal decisions. What do we invest in healthcare? So I would now ask my first speaker, Dr. Dalia Dawoud, to join us. Thank you.
Thanks a lot, Kawaldip, for the introduction, and I'm really delighted to join you today. And we've been tasked with a very important question, I guess me and my co-speaker, Dr. Gad, to answer whether African universal health coverage 2030 could benefit from health technology assessment. And as a start for my presentation, I thought it would be very important to just put the first background to our discussion today around the role of HTA, both now, how it's functioning, and in the future, and how we imagine it will be, or we are hoping it will be also in the future. So in my presentation, I'll start quickly by giving just how we define it and its role in healthcare decision making. And then in the second half, I will just quickly present our project that we are currently working on, which is called HTX, or Next Generation Health Technology Assessment, describing the project, what does it cover, its objectives, and how patient organizations are involved, and how they are actually at the heart of how we are developing the practice of health technology assessment going forward in the future. So I guess I don't need to reiterate this much, and you will hear more about that perhaps in the next presentation as well. That internationally, actually, healthcare decision makers are making resource allocation decisions all the time, and we have seen it firsthand during the current pandemic, and the amount of different possibilities and interventions that could be used to mitigate it, and how we need to make decisions about what to do and at different times. And these decisions really involve making difficult choices. So, by definition, there is decision making involved, and there are choices that bear with them or are associated with what we call an opportunity cost from economic terms. So, the money spent on one intervention is no longer available to be spent on another intervention, and this means that there is a cost for the choices that we are making. So it's not really about how much money do we have to spend, but rather how we spend it. And I want just to quickly illustrate it by the current status of the healthcare spending in the USA. So healthcare expenditure, as one example in the USA, it's the highest across the world. So if this study looked at comparing USA spending with among 12 industrialized nations. This was done in 2012 by the Commonwealth Fund. And it was clearly, we know that the USA actually spends the most per person on healthcare annually across these countries. And this actually across all different resources that are used in healthcare. So the Americans pay more for the same healthcare goods and services. Most commonly prescribed drugs are highest spending in the US. Physician fees for hip replacement were compared across countries, and the USA again is the highest, has the highest fees for physicians for hip replacement. And there's unproven quality. So whether this spending results in higher quality healthcare or not is debatable. And in fact, when they looked at within that survey, older adults in the other 11 countries, it was clear that that compared with their counterparts in 10 other industrialized nations, older adults in the US are sicker and more likely to have problems paying their medical bills and getting needed health care. So it's just one example, and you will hear more, I guess, on this from Mohamed across more countries. So the higher spending, more money spent on health care doesn't really equal better health. But what we need to do and to ensure is that we are choosing wisely. Are we spending on the most valuable interventions? Are we prioritizing value in our spending? So are we considering both costs and value of the interventions that are being funded or provided in healthcare? And this is really at the heart of what health technology assessment is useful in. So by definition, health technology assessment is a multidisciplinary process. and it uses explicit methods to determine the value of a health technology at different points of its life cycle. So really the purpose of HTA as a practice and as a tool to inform decision-making is that it is flagging or identifying the interventions that are of highest value per pound or dollar or euro spent. So the purpose is really to be used as a tool to inform decision-making in order to promote an equitable, efficient, and high-quality health systems. This is literally the latest definition of HTA that has been put forward by Health Technology Assessment International and INATA as organizations that work with HTA agencies across the world. And it really encompasses what is the real added benefit of using health technology assessment. It's about identifying what is value for each pound or each, for what's value for money, essentially. However, it's important to say that what constitutes value would differ from one country to another, from one jurisdiction to another. And there is a lot of work being done on identifying what elements of value we need to consider when we make decisions about funding interventions. And the International Society of Pharmacoeconomics and Outcomes Research has put forward some conceptualization of what elements of value that countries and societies could consider when they make decisions about what constitutes value for money. And at the heart of it, of course, is considering clinical effectiveness and the net costs, but also there are other aspects of value that we need to consider. For example, equity and the severity of the disease that we are looking at, including other elements of value. So really there is a decision to be made when countries consider implementing HTA in practice is that which elements of value that they will use within a health technology assessment framework. And who decides? Actually, this needs to be done in a conversation with multiple stakeholders. So society, by definition, should be the key decision maker in determining what aspects of value to consider when we assess different interventions that are funded, different healthcare interventions that are funded. And this incorporates, by definition, patients, carers, clinical experts, scientific experts. They need to be at the heart of the decision-making process when it comes to deciding what elements of value health technology assessment agencies should consider in their assessments. So I presented one possible definition of HTA, but there are a number of them. And as eloquently put by the WHO, there are many definitions of HTA. It emphasizes, but all of them emphasize actually the role of HTA as a tool. So it's not, and the HTA organizations are not making the decisions, but they are informing the decision makers. So they are providing a tool to support decision making at the different levels of healthcare systems. So it could be at on the national level, it could be on a regional level, it could be on hospital level, applied HTA in decision making. They also emphasize its multidisciplinary nature and the fact that it has a strong reliance, as we will see in the next presentation, and on the transparent, scientific, and rigorous methods in its implementation and its use. And this is why in many countries, and perhaps the European region is leading the way in having HTA agencies or bodies or organizations that are essentially tasked by assessing health technologies, including medications, but also other technologies. So technology doesn't only refer to new medicines, but it could be any intervention, a test or a procedure or a diagnostic or even now digital health technologies are being assessed by HTA organizations in order to offer guidance to health system as to whether the technology is worth actually investing in. And as I mentioned, it could be national, regional, or hospital level HTA implementation. And the most important is the joint working across the decision maker or the regulatory and HTA organizations. So the regulators would look at how whether an intervention is actually safe and effective and of high quality, and the HTA organization would look at whether it is representing value. And this is why many of the HTA or almost all HTA agencies work really very collaboratively with regulatory agencies, and this is being promoted even further. some would consider that adding this extra hurdle, or consider having HTA as a fourth hurdle in the process of having any technology accessing the market. So you have to go through registration and licensing by proving safety, efficacy, and quality. And now you also need to consider proving value for money at the stage of market access, but also even going beyond that as an ongoing process. So making decisions for market access, coverage, pricing, reimbursement, and formulary inclusion would be reliant on assessing now value for money. However, this is not really what it is about. It's not having another extra hurdle, but I'm hoping that you will see by the end of this session is that HTA can actually help policymakers decide which technologies are effective and which are not, and define the most appropriate indications for their use so they can be targeted to the patient populations who are most likely to benefit. And it could also reduce or eliminate interventions that are unsafe or ineffective, or whose cost is too high compared with the benefits it offers. But it's not the answer for everything, and still more to be done in this area. So really, we need to be using, within HTA practice, we rely on the use of, for example, on randomized clinical trial as a source of evidence, but we need to be now moving towards using wider ranges of evidence, to real-world evidence or data collected from observational studies, from patient preference studies, and also qualitative evidence to inform HTA methods. Also, HTA tends to make recommendation for the cohort or for a patient population that's part of the marketing authorization population, for example, for a drug. But more and more, there's a need now for more individualized approaches that can identify patients or patient groups of individuals who are most likely to benefit. And this would help really address any inequalities in the decision making. And this is why there's a lot of interest and funding being put in developing HTA methods to be fit for purpose and to future-proof these methods, actually. And one of these projects that we are very fortunate to be part of is the HTX project, which is the Next Generation Health Technology Assessment project, as I mentioned. And this is the project that NICE is collaborating on, specifically our science policy and research team. And it's funded by the Horizon 2020 European Union funded European Union funding. And it runs from 2019 to 2023, so we are almost halfway through the project now. And we have been doing a lot of work in order to achieve some specific objectives from this project. So HTX objectives literally are about creating a framework for next generation HTA that supports patient-centered, societally oriented, and real-time decision-making for integrated healthcare throughout Europe. So the focus is on Europe, but essentially we are taking an overview that could be applicable and applied to other countries outside of Europe as well. We are aiming to facilitate the development of methodologies to deliver more customized information. So as I mentioned, it's very important focus on individualized decision-making. So we can give clinicians and patients more customized information in terms of what works for them, what's effective, and what's cost effective, especially with all the innovative technologies that and drugs, for example, that we are coming across, complex and personalized combinations of treatments. So if you have companion diagnostics that are used to inform decision-making in terms of which treatments to be given to which individuals. So we aim to develop these methods and tools to facilitate implementation. And this will allow us to provide methods to support, as I said, personalized treatment advice that will be shared with patients and their physicians and help share decision making. So the concepts really behind HTX is having the input from all stakeholders involved in the methods development of HTA, so that the future of HTA is really inclusive of the input from all different stakeholders, and at the heart of it, really, patient organizations and patient involvement is key for that. So really, shared decision making is at the heart of what we do in the HTX project. And at the moment, we are working on developing tools to support this process, especially when new methods are being proposed. So how we can use specialist tools to help share decision making between patients and clinicians that make use of new methods that for example, using, as I said, real-world data or AI-based technologies. So this will be very important output that we are aiming to achieve from this project. And we have patient organizations involved in methods research. This is a proof of concept that really patients should be included from the start of thinking about a new method. So when you are innovating in terms of what new methods that you can use, you need to involve and partner with patient organizations in doing that. So literally, in conclusion, I just wanted to give you a quick start of the discussion, and Mohamed will expand on that HTA is really very important tool that inform healthcare resource allocation in order to ensure achieving value for money. And advancing its methods is important to ensure it addresses the most important challenges facing healthcare system. But this needs involvement from all stakeholders, and at the heart of it really is including patients and the public in the process. So that would take me to the end of my presentation. Thank you very much. And we would love to have you following our progress within the HTX project on our website and via all our social media channels. And I'll hand back to Kawaldip. Thank you.
Very nice to hear about, especially on the HTX. I think the applicability across the world is really important for us. And I think from initial stages when NICE, I remember, came up, it built up steam slowly. But then the criticism level was it was getting too technical and not bringing in the other voice. So this brings in greater voice and greater understanding. And I think also, as I say, as more people get interested in HTX, they're developing their own capacities. I know patients that I go with are taking up courses at the London School of Hygiene and Tropical Medicine, by the way, Mohamed. So they're taking up little courses on health economy, unit 6, 7, I think it is. And so it's good. So I will now pass on to Dr. Mohamed Gad to talk about what's happening on the ground and how is that taken up. Thank you.
Thank you very much, Kawaldip. Thank you very much, Dr. Dalia, for your presentation. I'm really happy to be here to be talking about HTA for universal health coverage, to be more specific. And I want to focus my presentation a bit more to pick up from what Dr. Dalia has been introducing in terms of a concept for health technology assessment, and try to put it into context with regards to how we've been running our portfolio of activities in Africa, in Asia, and other countries as part of the International Decision Support Initiative. So my name is Mohamed Gad. I'm originally a medical doctor, and I've been working with the IDSI since 2017. We are, as a bit of a background for this network, it's a network of healthcare practitioners, of governments, of academia, and they all work towards supporting decision-making low middle-income countries to actually inform decisions using evidence. And definitely health technology assessment is one of these tools that enables you to inform decision-making using evidence. So for me today, I'll be talking about mainly an overview of our presentation. Will include what is universal health coverage, how is the situation currently in Africa, what is health technology assessment, and how can it be linked with UHC in so many ways. And we will end by including some examples from IDSI work and perhaps some thoughts on African patient engagement, just to get us started with the discussion and questions and answer. So universal health coverage, I think, is a bit of an interesting concept. It's a very powerful concept. It is a concept that mandates that we have to ensure that everyone has health services they need without suffering financial hardship when they pay for them or when they access the health service. And you probably have seen this very popular cube that actually includes so many dimensions that you have to think about when it comes to universal health coverage. So the word universal might be a bit tricky, because what is universal? So what is universal health coverage in the UK may not be so universal in Ghana, for example. And what is universal from one person to the next is different. And of course, this entails a bit of a value judgment about what do you consider is a holistic, collective healthcare packages that would service or serve your needs in different demographic, in different epidemiological contexts. So in a way, that's one side of the argument about the universal health coverage, about who is to be covered, what services to be covered, the direct costs, or the amount of cost that could be covered. The second dimension that I want to mention with respect to UHC is actually how UHC is delivered. So of course you can have everything you need in terms of financing, but if the machine that the finance is injected into is not working, then actually the finance or the money would be wasted. And I'll comment about this in few moments. But for now, let's focus on this definition and divide it into main big aspects. One is this hospital logo, which means the strong, efficient system, essential medicines and technology are available, sufficient capacity of HR who are trained and motivated, and a system to finance all of that. So in a way, we can divide it into these two big notions: the system itself and the financing of the system. And I just want to say again that this is such a powerful concept, as Dr. Margaret Chan, the WHO Director General, mentioned, that the UHC can be the way for a lot of countries out. However, we will try to break it down from a bit of contextual point of view. So when it comes to tracking UHC, this is the WHO 2017 Global Monitoring Report, and it shows you three main dimensions where you need to look into with regards to UHC. First, the financial protection aspect, the service coverage, and the equity. So these are the three main elements that they look into when they track UHC. Of course, you need to have service coverage that helps people. You need to cover for them financially so that they won't fall into catastrophic payments, or they won't fall into impoverishment or financial hardship. So we're following the definition of UHC. On my right-hand side, you can see the map. The greener it gets, this is a map of the UHC service coverage index. So how much service is available in terms of coverage. And you can see here, the less greener area, unfortunately, is in Africa and sub-Saharan Africa, where there is a bit of a lower index value. Of course, in Asia as well, but to more extent, I would say in Africa, it's more pronounced. So obviously, we've got an issue when it comes to service coverage. That's one of the components for UHC. Let's go also into financing or the coverage of these services, just going into the financial protection part of it, and why is it a bit problematic. This is a map which is customized, by the way, Wikipedia. It's a very general map. I think this is yet to be done, where we want to study where the countries that have a lot of national health insurance scheme. I searched for a more comprehensive map, but I couldn't find. But this is a bit of an illustration where you would find there's many systems to cover for healthcare. So, for example, national health insurance schemes like the UK, like Rwanda and Ghana in Africa, in most countries that made a bit of a progress when it comes to UHC. But apart from that, you'll find the majority of patients relying on community-based health insurance schemes, or relying on out-of-pocket, or even if they're part of a national health insurance that is not functioning properly, they would need to go through the services on their own. And part of this is, of course, covered by the charity care organizations as well. So we've got a bit of also a problematic start when it comes to the financial protections. Now, to ask ourselves about finance, then are African countries really prioritizing healthcare spending? Is healthcare one of the main agenda items, political agenda items in African countries? And unfortunately, you could see here that half of the sub-Saharan African countries are spending now the same or less what they were spending on health in 2000. So you could see here in this graphic, this is the change in government health prioritization, and you can see that the percentage change is a bit low. There was a meeting in public financing for health in Africa in Abuja, to link it to the Sustainable Development Goals, and there was agreements about hopefully improving this indicator, improving spending or improving prioritization. But to give you also a more in-depth view here, you will find, for example, these are two main aspects that you measure when it comes to financial protection. Catastrophic spending, so this is how much you spend out of your household. They measure it at 10%, and they also measure at 25%. And you can see in this graphic here that we have a bit of a problem when it comes to catastrophic spending. So African countries in green, you can see actually is increasing catastrophic spending when it comes to 10% spending of your threshold of your household. Also the 25%, you can see it's marginally also increasing. In Asia, it's still a big problem as well. So this one aspect of measuring how well we're doing in UHC, it's still a bit lagging behind. And of course, impoverishment also follows similar trends. So a bit of reduction, then increasing, and then here a bit of reduction also, but then increasing. Now the poverty, they measure it based on $1.9 poverty a day poverty line, or 3.10 day poverty line. Choose whatever indicator you want, but whatever you look at, you'll find also the numbers are not, or the evidence are not supporting that there is a strong financial protection scheme in Africa. Let's go into equity, which is the last part of the UHC tracking. And you can see here, there's gaps in service coverage that remains largest in poorest quintiles. So in poorest quintiles of the population, they have bigger gaps. And if you look at this graphic and the life expectancy at birth and health coverage inequality, you'll find that the inequality, the ratio between the bottom quintile and the top is actually on the x-axis, and on the y-axis you'll find the life expectancy. As you can see, the more inequality, the lower life expectancy, and the higher and the less inequality, the higher life expectancy. So these are crude indicators, but it gives you an idea about what is the issue when it comes to equity, and why is equity so important when it comes to improving healthcare in countries in Africa. If you look at this red bars here, you'll find that these are bars that of the poorest among populations in Kenya and also in Tanzania, and you can see how much health expenditure they're paying, or would compare to, of course, the richest quintiles. Now, I want to end the UHC bit about with this graphic, because some countries in Africa has been developing. So some countries in Africa have been gaining momentum in terms of economic growth, and therefore they're having a richer atmosphere, sort of, which means spending in health you would expect would actually increase in economic growth, but that's not the case, unfortunately. So if you look here at the population with out-of-pocket health spending exceeding 10% of household budget, you'll find that upper middle income countries actually have more problems than low income countries. Look, if you look at here, this is the percentage of population graphic. So you'll find that the upper middle income countries actually are spending, a higher percentage of people are spending out of pocket compared to low income and high income. So we've made progress on low income, not a lot of progress in countries that are actually improving, which quite shocking. Now, you might wonder why these problems exist, whether we have the money, whether we don't have the money in Africa. Now, large part of this is that health systems are everywhere under pressure. As Dr. Dalia mentioned, there's a lot of, there's finite budgets, there's a lot of interventions to cover, there's a lot of healthcare needs, and you need to prioritize your way. Not to mention that 20 to 40% of the 8 trillion spent annually on healthcare is wasted. And that's the words of the WHO in their health systems financing report. And also about a fifth of healthcare resources is wasted. So we've got a bit of a dual problem here, where if money is available, it's wasted. If money is not available, we have issue of actually procuring and covering these. And you can see here, for example, if we ask about whether this is money, this is the African average, this is the Abuja target, which is 15%. Of total public expenditure, and you can see that the majority of countries are still below the target. But even this, it's just not just about the money as well, because countries here, if you look at this graphic, which is maternal mortality and public expenditure in health, if you look at how higher expenditure quadrant here with Namibia and South Africa, you'll find also it's higher in terms of mortality. So this is the mortality on the y-axis. This is the this is the expenditure on the x-axis, and as percentage of GDP. And you can see here in Namibia and South Africa is spending more than Gabon and Nigeria, for example, or Uganda, but achieving actually lower indicators by maternal mortality, lower indicators of health outcomes. So in this case, we've got more money and less health. So in a way, the UHC cube, back to the UHC cube, you can see that there's many dimensions to include. There is the financial coverage part, there's the service coverage, the financial protection, and the equity consideration, and you need to make a lot of decisions. So in a way to actually summarize this section is that there is no UHC without priority setting, and there's no priority setting without HTA. And that is what would lead to our definition of health services they need at the time they need, of UHC being actually effective in any country. Now, health technology assessment, as Dr. Dalia mentioned, I'm not going to go into a lot of details with this section, but I just want to make a couple of points here. It's basically an explicit way to make decisions. And I want to use the more friendly definitions, for example, like these questions. So HTA actually answers questions about the technology that you have, whether it's a drug, medical device, operation, procedure, policy, you name it. For whom does it work? For how well does it work? At what cost? What other attributes do we need to look at, etc. If you do this in an implicit way, like here in this graphic, then you probably end up with the wrong decision because you're not taking a lot of factors into consideration. But if you do this in an explicit way, where you actually list everything out and try to study things explicitly, then chances are you'll be better at including unintended consequences or accounting for unintended consequences, which in my opinion is one of the biggest values of health technology assessment, is to uncover these unintended consequences. Now, in essentially HTA is these 5-step process where you define, and I don't want to go into institutional definition, but I want to go more into general definition. So you define a decision space, you define a problem, you go into what is the analysis required, you convene stakeholders to appraise the analysis, you make a decision, and then you implement. Now, when I say HTA, I want also to shed some light on the products. So what is the products of HTA? How can this really benefit me as a patient? So down here, you can see some examples. So you can come up with an essential medicines list. You can come up with that covers actually what you need to have. You can come up with a health benefits plans for the health insurance using health technology assessment. You can come up with standard treatment and pathways. And I want to focus on that a bit more. If you look here, if you have evidence and you have an evidence-based approach in your healthcare system, then you're likely to study using HTA, these evidence, to actually design clinical guidelines and pathways. And from there, you can set quality. So HTA can also affect quality. It's not just about finding the drug or the intervention. It's also about quality standards. And also you can link that quality with payments. So you can pay only based on quality, which is based on evidence, which is based on health technology assessment that has looked into analysis of a lot of clinical and cost effectiveness data on intervention. So this is in a nutshell just how a very quick snapshot of how HTA can help. Now this is a holistic, let's take a helicopter view to see what is it like in reality. So we've got here a graphic with health benefits per $1,000 and healthcare expenditure on the x-axis, and this is the budget that we have. And imagine you have the benefits package, and these are the benefits. Each benefit, these are the interventions. Each intervention is from highest to lowest in terms of the health benefit. And you can see here, here's the budget, and the threshold we have is the lowest intervention in our lowest value of intervention we have in our package. And then we have new candidates, new drugs. Let's say here they are. We've done the analysis. We can see they're more beneficial. Some of them are more beneficial than the one we include, and therefore, except these two red parts, for example, these are lower than the current packages that we have. Now, if we embed these into our benefits package, they will push the less effective packages or the less effective interventions outside. And therefore, you will end up with a health benefits package that is more beneficial in terms of health, and actually your threshold even could increase, as this example shows. So this is just a quick example to understand how HTA can influence revising health benefits package, for example, if you want to focus on the health component only. And here's the net health gain. Now, I want to finish my presentation with very quick examples of what we've been doing. So we've been involved in Ghana since 2010, and actually we've helped convene interdisciplinary groups around health technology assessment. We've provided technical assistance since that date on major disease topics such as hypertension, diabetes. We've convened stakeholders meetings in Ghana where we discussed HTA from the national perspective. We're very conscious that HTA might not look like the UK, might not look like the developed countries, or might not look like high-income countries. Every country needs to decide on their own composition or formulation of how they want HTA to benefit them. And that's why you need to have that process really led and owned by people in African countries. Here's a very quick demonstration of how HTA has helped us with hypertension. In Ghana, we've done a cost effectiveness analysis for hypertension drugs. And we estimated that 10% price reduction actually can help generate over $5.6 million saving, which is enough to treat untreated patients of hypertension in Ghana 4 times over. So imagine the power of an analytic like that. How can you use that actually to improve your pricing strategy, for example? How can you use that to help extend coverage to people who are not currently receiving treatment in Ghana? We've always tried to foster change, and luckily we've seen a lot of change in Ghana. So Ghana has launched a national health technology assessment structures. Right now it's in the form of committees, and you can see here some pictures from the event where it was launched. Ghana right now are working on their strategy for health technology assessment, how they would choose to deploy this powerful tool for their own advantage in terms of healthcare spending, in terms of healthcare planning. And we also continue to convene multi-stakeholder partners. We work with other partners around who are actually in Ghana to actually help coordinate our intervention and our support to our colleagues there. Lastly, how can the million-dollar question, how can we strengthen African patient involvement? I think patients need to be involved right away. They need to be involved in the process. They need to be involved in the outputs. And here, this graph shows a bit of what components they can be involved in. And on the right-hand side here, I've got an extract from a study that shows you in Scotland, England, and Netherlands, what is the role of patients. And you can see the role here is mainly on the appraisal part, where they sit on committees, give an opinion from a patient perspective. But I see that patient needs can extend much beyond that. They can extend from the defining space here. So you can actually have patients organizing themselves into organizations and actually proposing topics that needs to be assessed. Or they can be on the assessment part if we have patients organization or patient members who are active in terms of technical activities and work. Implementation side and quality, as I mentioned earlier, the quality of care, how can we use HTA to improve that? Outputs, these are the outputs that I mentioned previously. I think these are outputs that are made for the patients, and simply if patients are not involved in producing these outputs, then these outputs may not be as effective as we hope they would be. So this is my presentation. This is a bit of a quick overview of IDSI and the countries we work in. We work in Kenya, South Africa, we work in China, in India, Indonesia, the Philippines, Vietnam, and these are the indicators of amount of population that we can influence by our work in IDSI, and that's I'm really a very encouraged person to be part of this huge network that support people, and I would invite everyone to use these tools, for example, that we generated for lay audience and other people who are not specialized in technology assessment. For example, what's in, what's out, health technology assessment toolkit, which helps you build your HTA or think about what you need to build HTA in your own country, and also reference case for economic evaluation that we started back in 2014. Some acknowledgements, and I'll end here, and thank you very much for your time.
Very good. I think you laid an overlay quite nicely. Now for the questions, I think they first have combined both together. The first question for both of you, and you can, is that how can patients access knowledge? Are there toolkits? Are there information sites that, say, for instance, from NICE or from IDSI? How can they get engaged in this? And the second one is, will you consider setting up national programs for patients in African countries if patients come forward in large numbers? Thank you. Dalia?
Yeah, sure. So NICE has a specialist team for working with patients, actually our patient and public engagement teams, and they are always in contact with patient organizations, facilitating their contribution to health technology assessment. So our TAs and also in our all other products, so clinical guidelines. And there's a lot of or many tools that they can make use of in terms of patient education and how they can engage in the process. So definitely there are tools out there. Within HTX, also our major partner in the project is EuroRDS, who is a patient organization across Europe for rare diseases. They are also organizing summer schools for patients to join in, and fellowship opportunities to learn about HTA and the new advances in HTA within Europe, and what we are doing specifically within HTX as well. And part of that is actually educating patients on how to be involved in these decision-making processes. So I guess perhaps this is more advanced in, I'd say NICE is a little bit more advanced now in terms of patient and public engagement, but for other countries where health technology assessment is not as advanced, they are just starting, and there is a need for a lot of support for organizations being developed in these countries to advance patient engagement. And perhaps Mohamed would be best positioned to perhaps in as part of IDSI to comment on the available support from the team.
Thank you, Dr. Dalia. Thank you, Kawaldip. I think HTA is not just a technical exercise, and this is something we continuously say. So it's not something that just belongs to the people who are maybe more a bit of a technocrats, or they're more specialized in producing these analysis, because analyses in themselves are meaningless if you don't have a value judgment that is carried by a group of people who are, and imagine the end target, who is the patient, is the perspective or their opinion is not included. So everything that preceded that is meaningless if you don't have that intervention. So that's one. The second bit is on, just to address the question, is that how can they engage? I think patients in Africa are among the most amazing people you can deal with, amazing stakeholder group you can deal with, just because they're really motivated. They're working on these issues from a very strong internal desire, and we usually find a lot of positive and outcomes dealing with patients and engaging with them. For example, we've run a conference to talk about HTA and how it could help Africa in Ghana in 2018, and we had patients representatives, we had industry representatives, and we had conversations about how can we engage. Unfortunately, I wouldn't say in nascent HTAs or HTA systems are still finding their feet. It's hard to account for everything at the same time. So what we focus on right now as IDSI is we're trying to establish a process that would actually be solid enough to include all these perspectives and to include patients and to empower patients. From the patient side, I would say a good thing to do is to organize themselves, to create organizations, to have these kind of conferences like we're having this portal and platform to communicate and talk about and think about these issues. And as part of IDSI, we're very open to working with patients. And to conclude, I think we've have a huge number of our outputs are called global public goods, where we are actually convening a lot of our experience, putting it into documents, sharing it around. And we usually get downloads, we usually get feedback from patients, from people who are motivated to actually make progress on HTA. I would say if you organize yourselves inside the countries very well, if you're connected to a network or a federation like APC and others, then IAPO, then you're able to actually access a lot of pressure portals from nationally and internationally, and this helps our job. This helps us link well with people on the ground. It puts an urge to our work. So I would urge every patient organization or every patient involved in this work to keep the pressure on, because that's the motivating factor that will help bring all these people together to coordinate and do something effective when it comes to HTA engagement.
Thank you very much. I think that's very good. Now, last question is, we're running a little bit of short of time. Dalia, you partly covered it in last answer. How are you going to engage people with rare diseases? Because these are high-cost treatments. And earlier we had a number of patients talking about that. How are we going to include them in HTA? Maybe, Dalia, you could start by mapping something for us.
I'd say it's the same standard process in terms of patient engagement for any disease area, to be honest, and whether it is a rare disease or not, the patient organization need to be involved. And the more we try to engage, as Mohamed said earlier in the process, is the better. And that's where we are coming with the HTX objective, is actually to start a whole life cycle approach for any technology. So from the start to the end, really patient need to be at the heart of that decision-making process, or the whole process, basically. So, and I mentioned that the patient organization we are partnering with within HTX is a rare disease, is focused on rare diseases, so EuroRDS, because one of our case studies is in a rare disease, so it's focused on myelodysplastic syndrome, which is a rare disease. And I do agree that these are very difficult and sometimes very emotional areas to cover, and that's why specifically is very important to engage patients with these diseases in the decision-making process very early on.
Mohamed?
Yeah, just to quickly comment on this, this goes back to my presentation when I was talking about the universal health coverage. And what do you mean by universal? Of course, when you, as you've seen in the graphic, when you introduce new interventions, you're displacing other interventions. And of course, rare diseases come with a high price tag, which means treating one patient will probably displace thousands of patients. And that's the kind of philosophical dilemma that you fall into. So the question here is not really for outsiders to answer that, but for having an internal stakeholder dialogue to agree as what is our societal objectives. Do we want to raise funds to keep perhaps a pocket of money for these rare diseases when they and should arise, because also the expenditure is not going to be high as when you compare, for example, treatments for all hypertensive patients or all cancer patients or all diabetic patients. So the idea is to find innovative solutions together. Even that's a problem in the Netherlands, for example, with Myozyme. That's a problem in high-income countries as well. So, but the idea in the end is to define what is universal for you as a nation. Do we want to sympathize with people who are unlucky to get these rare diseases, and how can we find agreements to find and procure these drugs, or to have these emergency funds raised to actually help this? So it's something that has to be internally motivated and internally structured.
Thank you very much. So it is still health is still a political and economic choice mixed together. On the consciousness, I just want to tell you, I may have to buy a bigger freezer because of Ilada. All my neighbors here have been so generous this year. Because of COVID, I don't know why, I've been just receiving legs of mutton all day since yesterday, and my freezer is now really packed up. So I'm trying to look at ways to buy a new one and then get sort of distributed out. So you enjoy happy eat function, enjoy with your family, eat, as I say, healthily, and hopefully we'll meet again. And this time we may have to meet physically in Cairo, and the health minister has assured us she would really push this agenda for us. And thank you very much.